In the next year, I think that there will be some changes, which I guess we have had on the horizon for a while. And always these things are driven by evidence, and also the inclusion of factors in guidelines. And just recently, the CAP, IASLC and AMP guidelines on molecular testing were published, and amongst those guidelines were changes in the status of two biomarkers. One, the test for ROS1 gene fusion, which has now become a mandatory test. So I think, if not already in practice in centres, it will rapidly become something that is now routinely tested for. BRAF mutation testing is on the cusp. If not actually a mandatory test, it's on the cusp of being so, and I'm quite sure in the next year there will be an expansion of BRAF mutation testing. The other area, of course, where there is likely to be change is in the immuno-oncology field, where to date most of the evidence that we've had has been around PD-L1 testing. But we are anticipating data coming out supporting the use of tumour mutation burden testing. Now, if this becomes a reality for our practice with approved drugs, then it's going to pose a number of quite serious challenges because of complexity, cost and accessibility to a test such as this. And in fact, we have no consistency or agreement about what is the best method to measure tumour mutation burden. So we're going to have many issues to address, assuming that this comes to pass as a regular practice. We also have the question of the tumour microenvironment and the inflammatory component in the tumour, and how important this might be as a component of the biomarker assessment. In some ways in lung cancer, this factor or this area is less well developed. I would anticipate seeing more data coming forward, but I'm not sure in a year's time we'll be able to implement it in clinical practice.